Hey friends, welcome back to the journal feed. My name is Nick Zelt, and this is the only place where you get to be spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's summaries, which this week were brought to you by our authors Aaron Lacey, Jason Lesnick, Megan Hilbert, Amanda Matthews, Millie Casse, and Clay Smith. Okay, let's get straight into the first article, which was titled Clinical Policy: Critical Issues in the Management of Adult Patients Requiring Endotracheal Intubation in the Emergency Department, out of the Annals of Emergency Medicine. Now, this is a clinical policy put together by ACEP, just making some comments on two questions, primarily when they can make recommendations on how you should be intubating patients and what you should be doing surrounding intubation so that patients are as safe as possible. These recommendations were put together by emergency physicians, medical librarians, and some patient safety advocates. Alright, so the first comment was on what peri-procedural interventions can help reduce hypoxemia. They had no level A recommendations, but as a level B recommendation, they recommended that when feasible, pre-oxygenation with non-invasive ventilation was recommended. Again, to reduce the rates of hypoxemia. And then if you look at level C recommendations, well, they say that if non-invasive ventilation is not feasible, then high-flow nasal cannula may be beneficial. They say that you should probably be using videolaryngoscopy over direct, and just as an author consensus, using apneic oxygenation is also something that they sort of recommend. Some things that they do not have enough evidence for is to justify recommending checklists, the ramped position, and if anything it was harmful rather than helpful. And then finally, stylets versus bougies, they did not have enough evidence to really weigh in there. And then the second thing that they wanted to comment on was what peri-procedural interventions may reduce hypotension. There were, again, no level A recommendations. They did have a level B recommendation, though, for the use of either etomidate or ketamine as your induction agent to hopefully reduce rates of hypotension because, again, these are going to be hemodynamically stable agents. Then there was a level C recommendation to avoid fentanyl, midazolam, or propofol for induction agents because they may cause hypotension. They could not comment on the doses of ketamine or etomidate that you should be using, and there didn't seem to be a difference from the trials that they cited that you were better off using lower doses of these agents. So you should just properly do an induction with them and don't try to skimp by on the smallest induction dose possible. It doesn't seem to necessarily be beneficial. As I said, avoid fentanyl. Pre-treatment with it may cause hypotension. And remember that hypotension is always worse than hypertension, which is typically what you're trying to avoid when you're pre-treating with fentanyl. A fluid bolus given before or during intubation has limited evidence and no benefit has really been shown thus far. Okay, so as ACEP makes these recommendations, these, again, are not level 1 recommendations, so you don't have to necessarily institute this all the time, but it should be something that you're thinking about if you do have the time. Non-invasive ventilation pre-intubation has been really gaining in popularity and is a level B recommendation, so when it is feasible, or if it is feasible for you at your shop, it's something to consider. Alright, in a spoonful, there are many things that you could do to try to prevent peri-intubation hypotension or hypoxemia. But not many of them are actually evidence-based or really going to make a difference. The clearest evidence that we have so far are to use ketamine or etomidate as your induction agent, try to avoid fentanyl, and then as for hypoxemia, non-invasive ventilation seems to be beneficial. You should be using a videolaryngoscope. You can consider using high-flow nasal oxygen and apneic oxygenation, perhaps. Okay, and then let's skip straight to the third article, titled Identification of Children with Positive Ultrasound and Appendicitis Using the Pediatric Appendicitis Risk Calculator, a Retrospective Cohort Study, out of the journal Academic Emergency Medicine. Now, we've talked a lot about appendicitis before, and it's a relevant topic because, of course, it's the most common surgical emergency to have in children. Currently, the false positive rate in the United States, that is how many children you actually bring to the operating room, you take out their appendix, and they didn't have appendicitis, it's about 6.7%, whereas the benchmark goal is to be under 2%. which is a huge difference because historically, the accepted number was 20%. And so we've made leaps and bounds here. But it's going to be really hard to get to under 2% when the false positive rate of an ultrasound, which is the go-to modality, is 10%. And how are we going to squeak that number down to less than 2% when ultrasound, our definitive imaging study, is holding us back? These authors figured, hey, why don't we use one of these risk calculators, the Pediatric Appendicitis Risk Calculator, which I'm going to just call pARC. What if we combine the two? So that you would need more than just a positive ultrasound. You would also have to be a high-risk patient in general. And this makes sense because now we're going to have an ultrasound that says you're positive. You've already got a pretty high pretest probability. So we just need to bump it up a little bit more so we get to less than a 2% chance that you don't have appendicitis. And when they ran the numbers from this retrospective study, they found that if you just had a positive ultrasound, again, it's about a 10% false positive rate. So you've got a 90% chance of actually having appendicitis when they take out your appendix. And if you combine that with a pARC score that says that you have a risk of over 25%, so that's moderate to severe risk by the pARC score, then this would mean that you have a 98.5% chance of actually having appendicitis, which leaves just 1.5% of kids who would get a false positive and would have their appendix out but not need it. And this gets us below 2%, which is what we're looking for. This is an interesting study to look at because this would change management. This would mean that you get an ultrasound, it's positive, and then you look at your pARC score and they're less than 25%, that you do not take that patient to surgery. You actually consider further evaluating them. Maybe you get a second ultrasound, or maybe those are the kids that go for a rapid MRI of their belly to confirm that this is the case. This is kind of interesting. And if we actually want to get to less than 2%, we're either going to have better imaging modalities, or we're going to have to adopt some kind of approach that's like this. It would be cool to see longer term data on this kind of thing, since some of these patients are going to have their surgeries delayed because we decided to do further imaging on them even though they had a positive ultrasound already. And this is not the first time that we've seen risk tools combined with ultrasound. You may remember that a while ago we covered an article that looked at ruling out appendicitis in children. And in that article, we showed that if you had a non-conclusive ultrasound, most of which are usually negative once you repeat them or the way things shake out, and you had a low score on the Alvarado scale, then in those patients, it was worth not repeating the ultrasound and just saying, okay, you don't have appendicitis, you already had one equivocal ultrasound, which is probably negative, you're low risk by Alvarado, those patients could be sent home potentially. So this is not the first time that we're seeing the combination of ultrasound findings and risk scores, but this time we're using them to rule in the diagnosis, and that's interesting. But to me, this sure sounds a lot like, okay, you're not going to get a surgeon to come down to see your patient with appendicitis unless they need more than positive imaging. Oh my goodness, it's already so hard to get a surgeon to come see a patient. Without imaging, it's nearly impossible these days. But now perhaps imaging won't even be enough. Oh my goodness. But it's for the patients. We're thinking about the patients. We're trying not to do surgeries we don't want to do. And so I'm going to try to think of it that way. In a spoonful, in order to get to a less than 2% false positive rate, you would need to have a positive ultrasound and a pARC score over 25%. Otherwise, you might need more imaging to try to prevent taking out appendices that aren't inflamed. Okay, that's the 5 articles that we have from this week. What did we learn today? First, it's always surprising to me how little we actually know about even common things like intubations. The best way we can say right now, according to this ACEP policy, is that you should be using non-invasive ventilation for pre-oxygenation when you can, and then ketamine and etomidate are the preferred agents to try to prevent hypotension on induction. From the 3rd article, shaving down the numbers of unnecessary surgeries in children is something that should be important to all of us. Here, you had to have a positive ultrasound and be high risk by the pARC score in order to really justify having an appendectomy, or at least having a less than 2% false positive rate. Now, if you are hearing this right now and you are not a part of the members feed, then you missed 3 articles from this past week. What were the things that you missed? Well, one was a study about how community doctors are actually doing their intubations. Another was taking a look at intracranial hemorrhage risk factors for the elderly. And then finally, we looked at the HOPE trial, which was trying to extend the window for thrombolysis in stroke patients. Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.